you, Professor Mancebo. Thank you, Antoine and Daniel. Please don't kill me. Right. So let me start by discussing with you which is the death distribution of our patients suffering from septic shock in ICU. As you can see here, there is a peak in the early phase, but the majority of our patients die late during the course of septic shock. There are several explanations, including probably we are treated different kind of population. We are treating patients with comorbidities, with advanced age. But in addition, we have also to take into account what is the response of acute and pharmacological stimulation. And this is why septic shock is typically characterized by sympathetic overstimulation. And we know that sympathetic overstimulation may affect several pathophysiological pathways. And just for give you an example coming from France, this is coming from Marc Leone and co-workers. As you can see here, if the patient receive a norepinephrine dose close to 1 micrograms per kilo per minute, the possibility of death is very high, close to 90%. So again, there is a problem related to sympathetic overstimulation that is a hallmark of septic shock. So therefore, it's not surprising that beta blockade may modulate such sympathetic overstimulation and probably positively affect some pathophysiological implication. As you can see here, there is a lot of experimental literature regarding the effect on cytokine inflammation, metabolic alteration, and coagulation disorder. We are still waiting for a randomized trial in the clinical setting, but we have the majority of our study available in literature are, of course, are experimental. But there are some aspect that needs to be discussed. For example, it has been demonstrated that the administration of beta blockers may improve microcirculation. There are, of course, causes related to anti-inflammatory activity, but probably there is more, and there is still issue under investigation. There are also other group of patients, for example, patients suffering from acute lung injury or RDS, who may benefit from beta blockers administration because they're improving in right ventricular function, the fact that we decrease blood flow to the lung, and of course there is, again, anti-inflammatory activity. And again, here there is experimental literature in supporting such issue. So, but what to me is very clear is the fact that, as you can see here in this slide, this is the Albios trial in which the author demonstrated after 24 hours of hemodynamic optimization according with current guidelines that there is an increase in troponin level in the majority of our patients, close to 84%, which means that there is probably a myocardial direct damage linked to sympathetic overstimulation. And there is a clear relationship with mortality. So indeed, we demonstrated by giving beta blockers that we can protect the heart, as indicated by our data, in which we found a decrease in troponin level, and such results were replicated later. And therefore, there is a strong rationale in giving fixed dose of beta blockers in order to mitigate sympathetic overstimulation. And here there is literature to support this assumption. Of course, there is a retrospective analysis, but the data are very promising, and the number of patients investigated within these studies is very high, more than 10,000 of patients treated with beta blockers, and the message is always the same. There is a clear relationship between mortality and the administration of beta blockers. So, but to me, it's very important to discuss with you what happened in the early phase of septic shock. When we try to optimize hemodynamics, we have to take into account that what we do in the early phase probably may affect delay death of our patient, and I'll try to explain why. So we know very well that we give fluids, we give vasopressor agents, but if we give an excess of fluid and increase the vasopressor agent, probably there is detrimental effects on myocardial performance. And I want to discuss with you by looking at what we call ventricular arterial coupling, that to me is very important because there is a clear relationship between the pressure volume area and the myocardial oxygen consumption. This is the normal condition in which we have to rightly balance inotropic and afterload in order to provide the right ventricular coupling, which means that the ratio between arterial elastance and ventricular elastance is near 1. When we give fluids, indeed, we increase oxygen, myocardial oxygen consumption. And in addition, when we increase afterload with norepinephrine, we further increase oxygen, myocardial oxygen consumption. Not surprising, again, coming from the Albius trial, all the patients experienced an increase in proBNP, suggesting, and in the majority of the patients, probably all the patients, there was a problem related to ventricular arterial coupling. And there is an additional factor, which is tachycardia. You know well what are the side effects of tachycardia, but again, take into account ventricular arterial coupling, you have to remember that there is an effect per se of elevated heart rate, which means that in presence of tachycardia, the arterial tree is more rigid, and this increase, of course, arterial elastance. This is just a pure effect related to an increase in heart rate. And you know well that the force frequency relationship, which means that tachycardia is one of the crucial factors for increasing myocardial performance during stress, is totally abolished in the failing heart, including the septic heart. And again, if we take into account what is happening when the patient is tachycardic and we have give fluids and we have increased afterload, there is a reduction in stroke volume because we are in presence of the compromised force frequency relationship. So again, tachycardia contributes to decreasing myocardial performance. And there is I found very interesting study in which has been demonstrated that by using a sophisticated echocardiography technique, which is the left ventricular strain, the authors reported that in patients in which we give a lot of fluids, there is an impairment in myocardial performance, which probably may impact in the days following the early phase of septic shock. And again, there is another study coming from America in which there is a clear relationship with proBNP and mortality only in the septic shock patient. Again, suggesting that there is a problem related to inotropic in one end, after in the other end, and in the mid, tachycardia. So this is, to me, one of the most paradigmatic studies coming from Antoine, in which Antoine demonstrated that after 24 hours of norepinephrine, after 24 hours of increased afterload, there was a loss of myocardial performance, and Antoine and his physicians gave dobutamine for increase, again, contractility, which means that there was an imbalance between inotropic and afterload. And what is interesting to me, that again, the patient were tachycardic. So another contributing factor in the coupling ventricular arterial. So the problem is that we have to try a strategy to preserve myocardial function during the length of stay of our patient, which are suffering from septic shock. And at the moment, we have only to try to mitigate sympathetic overstimulation. And we can do this by decreasing heart rate with the right drug, which is beta blockers, of course. Just give you an example. This is a patient which is tachycardic. This is clear hyperdynamic state, which is probably the best indication for treat the patient with beta blockers. There is an impairment, not so high, but there is an impairment in perfusion. And if we reduce heart rate in such clinical scenario, what we are doing indeed is an economization of cardiac function, because we decrease heart rate, we increase stroke volume, and therefore we maintain cardiac output. This is just an economization of cardiac function that, to my opinion, is crucial. And how can we explain such economization? Of course, this is the patient after the decrease in heart rate. The first thing we have to take into account is what we do when we decrease heart rate in terms of ventricular filling. There is a better ventricular filling, of course, a better diastole, which may imply an increase in stroke volume. And indeed, there is some clinical studies which replicated our first proof of concept study, in which, as you can see, there was a negative impact in terms of or no change or decrease arterial lactate concentration or no repeating in doses, suggesting maybe could be safe such strategy in the right patient. Again, probably the diastolic phase, the ventricle filling play a major role, but you don't have to forget what is going downstream when we decrease heart rate. This is an example with another drug, which is ivabradine, and the administration of ivabradine is, by reducing heart rate, is associated to an improvement in arterial elastance. I remember again, arterial elastance is the best way to try to express what is the afterload, because it takes into account the compliance, resistance, and so on. And this is also true for beta blockers in other clinical scenarios, such as heart failure. The problem is it just the same mechanism? Can we use the same mechanism for reduced arterial elastance and thus improving ventricular arterial coupling during septic shock? This is, again, our first experience in which we demonstrated decrease in arterial elastance by using the most common formulas. And again, it's very difficult to analyze at the bedside the two actual components of ventricular arterial coupling, because arterial elastance is difficult to obtain at the bedside, and especially ventricular elastance. But the message is we need to protect the heart to try to improve the outcome of our patient. This is the last data regarding mortality in Italy for septic shock in 2015 was, as you can see here, 50%, which is still very high. So by adopting these strategies, it is out of doubt that Survive Sepsis campaign, the hemodynamic optimization according to Survive Sepsis campaign, probably has improved the early phase of septic shock and prevent the early deaths of the patient suffering septic shock. But we need strategies to try to improve the late death of septic shock. And among them, what we are probably do now and try to improve the late death is try to spare the oxygen consumption, not only of the heart, but also the other organs. And by doing so, probably we will improve the late deaths and thus the mortality rates until in Italy. So thank you for your attention.